Inotuzumab ozogamicin versus standard therapy for acute lymphoblastic leukemia. The prognosis for patients with acute lymphoblastic leukemia is poor. We sought to determine whether inotuzumab ozogamicin, an anti-CD22 antibody conjugated to calychemicin, results in better outcomes in patients with relapsed or refractory acute lymphoblastic leukemia than does standard therapy.
Today I presented the result of a phase 2 trial, essentially combining a new compound called Inotuzumab ozogamicin plus mini chemotherapy for elderly people. The rationale is the following. We know that elderly patients with acute leukemia and mainly ALL, they don't do well. We have a high mortality rate, survival is bad, and that was found across all the studies reported. And why is that? Because they have poor tolerance to chemotherapy. Therefore, the idea was to give lower intensity chemotherapy for these patients. Now, we have a new drug called Inotuzumab ozogamicin, which is a new antibody. It has a toxin attached to it called calychemicin. So this antibody binds to the surface of the cancer cell, and when it's bound, the toxin is delivered to the cell and kill the cells. In fact, it does attach the DNA and then break the DNA, and as such, the cell will die. So it's a very novel way. This drug has been assessed in refractory patients. It's found to be very effective with 58% responses in patients who failed prior therapy. Furthermore, in a randomized trial, it was found to be better than anything we have available. Therefore, the idea was, if this drug is so targeted and not toxic, maybe we can combine it with a low-intensity chemotherapy in elderly people. As such, we decrease the toxicity rate and the mortality, and we can improve overall survival. So we tested this combination in 38 patients. The drug was given at the beginning at 1.8 milligram per meter square in the first cycle, and at the lower dose, 1.3 milligram per meter square in subsequent cycles, for a total of 4 cycles. We found that despite this dose with combination, we have some problem with safety, essentially veno-occlusive disease, essentially it's a liver problem. We had to reduce the dose from patient 35 and moving forward to 1.3 for the first course and 1 milligram for subsequent courses. So these are milligram per meter square. We have 38 patients treated. The results are phenomenal. We have everybody but one patient responding. We have 95% of response rate, which is really good. More importantly, when we look at the patients with bad features, like they have the karyotype being abnormal, everybody responds. And then we look at what we call minimal disease assessment, which is we know today is one of the most important factors for the survival. We have everybody achieving what we call MRD negative status, of them 74% at the time of remission, which is day 21. So phenomenal. Now, of this trial today, we have a median follow-up of 2 years. We have a median overall survival of, we have 2-year survival of 64%. When we compare this data to historical data we have in similar patients, we doubled survival from 34% to 64%, 30% increase, which is really good. Now, it's still early on. We have to wait for data to mature further, but at least it's really very encouraging. Now, safety with the drug, we did see essentially what we've seen is similar to what we've seen with other chemotherapy, but we did see VOD, the problem of the drug. This is why we reduced the dose. We had 4 cases. 2 of them were mild reversible, and 2 of them were severe. That led to the patient death. That was a red flag. Therefore, we're reducing the dose of the treatment, as I mentioned at the beginning, to lower dose. And we're exploring further lower doses to see if we can keep the efficacy while we can decrease the safety concern, and that is ongoing. So overall, I can say the results are very encouraging. We have a high response rate, everybody achieving MRD negativity with a 2-year survival of 64%. Safety-wise, it's very tolerable. VOD, as I mentioned, we have to tune the dose of the drug. And if these results stand at the long run, they may replace the way we treat leukemia with a low-intensity regimen with minimal chemotherapy. These chemotherapy are very minimal, and we take advantage of the drug to further improve the outcome.
In this phase 3 trial, we randomly assigned adults with relapsed or refractory acute lymphoblastic leukemia to receive 80 inotuzumab ozogamicin or standard intensive chemotherapy. The primary endpoints were complete remission and overall survival.
I'm presenting today at ASCO the results of the INNOVATE trial, Inotuzumab trial by age of the patients. In fact, Inotuzumab ozogamicin, it's a monoclonal antibody that targets CD22, and it's conjugated to calicium-mycin, a toxin. So when a drug is bound to the CD22 at the surface of the cells, it's internalized, and then the calicium-mycin is delivered that causes double DNA breakage and then death of the cells. That is how it works. We assessed the drug in leukemias in a phase 2 study where we tried to schedule 1.8 milligram per meter square monthly and then 1.8 total dose, but given in multiple divided dose, 0.8, 0.5, 0.5 weekly. Overall, in refractory patients, we found 50% responses, although the weekly regimen was found to be safer with less complication, mainly VOD and liver disturbance. That led investigators, among them ourselves at MD Anderson, to take this drug into a randomized trial called INNOVATE trial, where patients were in salvage 1 or 2 were randomized to either standard of care, mostly received like either rubicin or inotuzumab on a weekly schedule. The primary endpoint was composite response rate and overall survival. We do not know the survival data yet. It will be presented at the EHA meeting in Denmark. We know for the responses, overall 80% responses. And then among the responders, they had an even deeper response, what we called MRD negativity. Now, as you know, the goal in ALL, when you relapse, you go for transplantation. Although that may not be the best approach for everybody, especially if you failed multiple agents, transplant will not lead to great outcome.
Of the 326 patients who underwent randomization, the first 280 were included in the primary intention to 3 analysis of complete remission. The rate of complete remission was significantly higher in the inotuzumab ozogamicin group than in the standard therapy group.
They affect and will suppose an important change in the treatment of ALL. Where we are now is that both inotuzumab ozogamicin and blinatumomab are very effective in relapsed refractory setting. And in this Congress, the results of 2 important phase 3 trials have been presented, and the last will be presented this morning, stressing that that these immunotherapeutic approaches are better in terms of survival versus the standard of care therapy. That's where we are now. But I think that the best place of these 2 agents and other agents that will come soon is in early phases in the disease, especially in first remission when there is still MRD to be eliminated. And I guess that these 2 agents will be very effective to eliminate MRD before the patient relapses. So I think the best future for these 2 agents has to come. But now there are important agents, and we will use and are using now, of course.
Among the patients who had complete remission, a higher percentage in the inotuzumab ozogamicin group had results below the threshold of minimal residual disease. The duration of remission was longer in the inotuzumab ozogamicin group. The survival analysis, which include all patients progression-free survival, was significantly longer in the inotuzumab ozogamicin group. In the severity population, the most frequent grade 3 or higher non-hematologic adverse events with inotuzumab ozogamicin were liver-related. Veno-occlusive liver disease of any grade occurred in 15 patients who received inotuzumab ozogamicin and in 1 patient who received standard therapy.
Recently, we started to move this kind of compound, before chemotherapy. In the past, there was invariable, in the majority of the patients, we do the chemotherapy before, and then we use these drugs in relapsed or refractory patients. Now we are starting to use these drugs in the frontline therapy, which is more promising because we get a rapid debulking of the disease, we get immediately restoring of clinical condition, and we can do more in our patients, for instance, getting more intensive chemotherapy later on, or bone marrow transplantation as a final consolidation of the therapy. So this is a very interesting way to use this drug. Of course, we can also use the combination of immunotherapy and conventional chemotherapy in the future in the frontline therapy. But I think it might be possible to use this drug in a very limited way in combination with chemotherapy. So the future will be without chemo.
The rate of complete remission was higher with inotuzumab ozogamicin than with standard therapy, and a higher percentage of patients in the inotuzumab ozogamicin group had results below the threshold for minimal residual disease. Both progression-free and overall survival were longer with inotuzumab ozogamicin. Veno-occlusive liver disease was a major adverse event associated with inotuzumab ozogamicin.